Patient is a 63-year-old male with past medical history of hypertension, hyperlipidemia, type 2 diabetes, and chronic kidney disease stage 3, presenting to the ED for shortness of breath with walking times 10 days. He reports that there's no known precipitating factors, that it gets better with rest, worse with walking short distances and climbing stairs, slowly worsening since onset. He describes it as he can't catch his breath, and that he gets shortness of breath sometimes but never this persistent. Rates it as severe. He couldn't leave the house for the past 2 days and has been constant since onset. His dad died at age 70 from an MI. Mom died at 74 from a stroke, and brother is 65, alive with hypertension and type 2 diabetes as well. For medication, he takes lisinopril 20 milligrams daily, metoprolol succinate 50 milligrams daily, atorvastatin 40 milligrams daily, metformin 1000 milligrams twice daily, and aspirin 81 milligrams daily, all orally, and he is allergic to penicillin. He gets a rash. He also reports weight gain of 5 to 7 pounds over the past 2 weeks, swelling of bilateral lower extremities, and orthopnea. He denies fevers, chills, night sweats, chest pain, palpitations, cough, lightheadedness, dizziness, and sputum production. Blood pressure is 148/88, heart rate 102, respiratory rate 22, and oxygen 91% of room air. Temperatures within normal limits. He's alert and oriented, no acute respiratory distress but mildly tachypnic. Physical exam, the patient's normocephalic with mild neck vein distension, no JVD present. He's tachycardic with a regular rhythm, has 3+ pitting edema of bilateral lower extremities, no erythema or warmth. The rest of the cardiac exam, as well as the abdominal exam and neuro exam, are unremarkable. And on the lung exam, he has mild tachypnea with bibasilar crackles and auscultation. He has an elevated BNP of 780, elevated glucose 156, elevated BUN 34, creatinine of 1.8 elevated, mild hyponatremia, and his CBC, CMP, and troponins all within normal limits. His chest x-ray shows cardiomegaly with pulmonary vascular congestion and mild bibasilar interstitial edema. EKG shows tachycardia, no ST elevations, and no clear P or T waves indicating an arrhythmia. So based on his past medical history, his clinical presentation of orthopnea, progressive dyspnea, the weight gain, the labs, and the chest x-ray, I believe he is in heart failure. I would like to admit him for inpatient treatment, refer him to cardiology and order an echo, get him started on IV furosemide, continue his current medications, and then pending the echo results, we could get him started on GDMT therapy, and then also a fluid restriction until the edema resolves. I'd like him to follow up with cardiology and his PCP pending the cardiology recommendations, and then if he experiences any extreme shortness of breath or chest pain, press the call bell for help, and then the discharge instructions will be pending the cardiology consult.